Today we are talking about a rare spinal tumor that presented with a lump on the back of the craniocervical junction, the back of the head and upper cervical region. There is a 9-year-old boy suffering from a lump in the back of the neck since 2 years ago, and this suffrage reached to the point that he was not able to do anything because of the constant pain and the deformity that this humps makes. Therefore, we're going today to operate and talk about this. 2 years ago, there is a biopsy, and this biopsy showed that there is a hemangioma. This biopsy was done in Iraq in the Divan Shah near Najaf, and they referred the patient to us for operation. Dr. Khamba will describe and tell about the patient.
Here, monitor. As you see here, lesion at posterior craniocervical junction. It was once underwent biopsy with report of hemangioma. This is the pathology report 2 years ago. Cavernous hemangioma was reported. At brain MRI, you can see the lesion. This is a very large lesion at the craniocervical junction with pressure to the cord and the left vertebral artery, which is better seen at the axial cuts. Here, it has pushed the left vertebral artery to the anterior. The patient underwent the studies of the arteries. Fortunately, massive tumoral blush was not detected, and the anatomy and pattern of the large vessels were intact. At the CT scan, you can see the lesion is a calcified, a mixture pattern of calcification and soft tissue at the posterior with scalloping of the posterior occipital skull. And this is the X-ray. The lesion is better seen. This is very large lesion. I think it's originated from C1 because the C2 lamina is intact and the spinous process. We can see the changing of shape of the skull here, and Professor Sharifi, you can describe how to.
During surgery, we found a very firm mass attached and originated. It's looked like that from the C1 lamina on the left side. We removed it, and there was a scalloping on the posterior squamous of occiput. It is very interesting that the tumor comes from outside of occipital bone and made scalloping over that. I've never seen like this. This kind of tumor is very unusual. It's not a osteochondroma or something like that. It near certainly is a low-grade chondrosarcoma that can make the scalloping of the occipital vertebra and atlas vertebra, and the tumor grows between this. This showed that the tumor should be low-grade, and yes, very slow-growing tumor can make this disfiguring appearance over the bone. And the most important thing was there is no adhesion to dura. It's very good. The dura separated very well, and the vertebral artery is also pulsating in the depths of the field intact. And there was very good reconstruction. We don't do fixation in these cases. Why do you think so?
I think at dynamic X-rays, we don't see instability at the occipital C1 and C2 junction.
This is the dynamic X-ray. Yes, the most important thing is preoperatively be ready for what happened during surgery. Because of this, we do flexion extension, but maybe in the time of surgery you are obliged to remove the faucet. You remove some things that makes instability. Therefore, we were ready, but we don't use the instrumentation as much as possible in these patients. And the patient is very well right now. Thank you very much.